I want to thank you all for attending. We have a great turnout this month because I think large part to our speaker and the topic that she's presenting. Let me tell you some about Dr. Jennifer Johnson. As she said, she's a medical doctor. She specializes in adolescent and young adult medicine. Dr. Johnson was formerly a professor at the University of California at Irvine. She now has a private practice in Newport Beach where she provides comprehensive health care for patients ages 10 through 30 years of age. Many of Dr. Johnson's patients have eating disorders, are in recovery, or both. While a professor at UCI College of Medicine, Dr. Johnson directed the Adolescent Medicine Program. She also has served as medical director of the Adolescent Inpatient Unit and the Adolescent Clinic at Children's Hospital in Oklahoma City. Very much like San Clemente, as I understand, Oklahoma City. They're very similar. Dr. Johnson is past chairperson of the American Academy of Pediatrics section on adolescent health. She has authored many articles and book chapters, and is a frequent and continuing education speaker here in Southern California. And please give Dr. Johnson a great round of applause.
Thank you very much. It's really nice to be here today to see old friends and colleagues and meet some new ones, especially Study. We've cooperated or collaborated on the care of several patients, probably over the last 5 years, and I've never seen her before, so isn't that nice? So thank you for all coming. I know it's a long way for you. This is going to be an interesting talk for me. It's sort of a new one. I did some reading for you because I'm a little challenged. You're a very knowledgeable audience, many of you. Many of you have dealt with eating disorders for years, substance abuse for years, and a few of you have been in programs that combine treatment for both of those entities. But in my experience, the recovery community is really just starting to address people who have an eating disorder and a substance abuse problem. So I wanted to talk a little bit about that today. However, please interrupt with questions or comments. It's a lot more fun when you contribute from your expertise, because a lot of you have quite a bit, and I am definitely not a substance abuse expert. I am a recovering academician, which is why I like giving talks. All right, so a couple of things today that I wanted to cover: the diagnosis and key management issues in patients with eating disorders. That'll probably be pretty abbreviated, and I've kind of woven it into my talk, but again, any questions, please ask. And I wanted to talk specifically about the links between bulimia nervosa and substance abuse, as well as anorexia and anxiety. These are things that kind of go hand in hand. All right, next slide, please.
I think you have to tap.
Oh, where do I tap?
On the screen itself.
Oh, sorry, I'm not used to high tech.
Wow. I want one of those.
Oh, this is great. I don't think I want to give it to my husband, though. He's in charge of the remote at our household. All right, quick review. Anorexia nervosa has a lifetime prevalence of up to 1% in adults. It's increasing in the proportion of males who have that case. It's increasing in the age of onset, so we're seeing pre-adolescents now with eating disorders or eating disorder equivalents, like I can't swallow my food. Bulimia nervosa has a higher lifetime prevalence, up to 3% in adults. And I think you probably know that overall the largest category of eating disorders diagnosis is the famous EDNOS, eating disorder not otherwise specified, where people don't meet the full diagnostic criteria for either anorexia or bulimia. And people are now talking as well about subthreshold anorexia and bulimia. That's going to be in DSM-5, and I'm not an expert on DSM-5. So those are the most common eating disorders, and as I said, EDNOS is the number one, and that appears to have overall a 15% lifetime prevalence, so way more than these narrowly defined categories. Next, oh, sorry. Okay, oh, how do I go back?
That I don't know.
I reach up here. Oh, okay, that was the next one. Thank you. We talked about that. All right, so there are a lot of other terms that come into this that may or may not eventually be classified as separate disorders. Purging disorder, which is where people purge but don't necessarily binge. Night eating syndrome, where people take in the vast majority of their calories at nighttime, often awake from sleep, in order to eat. Food phobia, which actually is fairly common among patients with anorexia nervosa. I had a patient once who had bad OCD, and when her therapist put a plate of cookies on the sofa, she could not tolerate that. That was really a phobia that she developed. Okay, food avoidant emotional disorder, exercise addiction. We see lots of that around here, and of course, it's hard to draw the line between addiction and healthy exercise, especially because people who exercise regularly in a healthy way get really frustrated if they have to miss a day at the gym. The woman with anorexia that I mentioned just now had developed actually OCD when she was 10, and she became my patient when she was 26. She was in agony trying to decide what to do on Thanksgiving Day when the gym was closed. And she solved that problem by walking for miles and miles on the beach. Okay, orthorexia, we mentioned that at lunchtime as well, where someone may not overtly have an eating disorder, but boy, they're focused on they're going to get that many calories of fat and that many of carb, and they have to have a certain body mass index and muscle composition. And there are gyms, including one here in Mission Viejo, where the personal trainer, in working with someone, will actually measure their body comp every week as part of their workout and say, yeah, you need to add muscle mass this week. It's a little too extreme, and I don't think it's healthy. Okay, the female athlete triad is something that I see a lot in my adolescent medicine practice. That's when girls who play volleyball or do a lot of cross-country running come in, and they're not having periods. And they're otherwise healthy. Their labs are fine. Deb, I know you work a lot with clients like that. And it's a challenge to explain to them that if you just eat a little more, you won't gain weight, but you will start having periods again. And that's one of the challenges that I deal with because, of course, they're already eating a lot. Okay, and then body dysmorphic disorder, which is really a separate category in which someone becomes so focused on how they look on a particular body part often that it impedes what they do on a day-to-day basis. All right.
I have a question.
Yeah.
You're talking about the trainer that measures body comp every week.
Uh-huh.
It's not really possible for body comp to change that quickly, is it?
No, I don't think it is. And this was a young lady who had anorexia. But he said she needed to gain weight, but she only needed to gain muscle mass, which is interesting considering that she had probably, 10% body fat, so she also needed fat mass. All right, binge eating disorder. There's going to be lots and lots more written and spoken about that lately. And this is a typical binge eater in that she's got that plate full of donuts in front of her. Binge eaters are not all overweight. And I think that's a really important distinction for us to make today is that binge eating and overweight are not synonymous. So this is the new definition of binge eating disorder that's coming up in DSM-5, which I think is going to be released later this year. Recurrent episodes of binge eating characterized by eating in a discrete period of time, which is usually counted as 2 hours, definitely larger amounts than most people would eat in a similar period of time under similar circumstances. So, eating a half gallon of ice cream at bedtime could be considered binge eating if there is a sense of lack of control over the eating during the episode, meaning you can't stop and you can't control what or how much you're eating. So maybe the half carton of ice cream would be normal, especially if you're a high school football player, but you can stop and you don't then reach for half a loaf of bread and a jar of peanut butter. The other characteristics of binge eating disorder are that these binge episodes are associated with at least 3 from this list of 5. Eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts when you're not hungry, eating alone because you don't want anyone to see how much you're eating. That's different from eating alone when you're anorexic and you just can't tolerate having someone there when you eat. And feeling disgusted for what you've eaten and just basically really guilty that, how could I do that? And then the final part of the binge eating disorder definition, the distress about the disorder regarding the binge eating, at least 1 episode a week for 3 months, and not using any of the compensatory behaviors that we see in bulimia nervosa, which is overexercising or purging. And just a technical detail, the binge eating is not occurring exclusively during the course of another eating disorder. So there's also going to be a category called subthreshold binge eating disorder. Binge eating at least twice a week for several months, perceived loss of control, and no history of another quote-unquote threshold level eating disorder. Is that definition or that term threshold level something that you're all familiar with or can imagine? Threshold basically means to meet the diagnostic criteria for an eating disorder, say anorexia, you have to meet a certain number of criteria. Subthreshold means that you don't have enough criteria to meet that diagnostic category, and you also don't have enough criteria to fulfill the requirements for that big EDNOS group. And I think the subthreshold eating disorders are the most common and they're the most difficult for us to get help with or to help our clients with because they don't meet the criteria for getting a higher level of care, meaning intensive outpatient or even residential care. It's really tricky with these people, and yet they can be very, very handicapped by their eating habits and thoughts. Oh, okay, now I'm going to go back. Okay. So I want to talk a little bit about, and it's a little bit about some really fascinating research that's been done in the last 5 years or so, in which people have very clearly demonstrated that you can make binge eaters out of any rat, presumably any human, under the right circumstances. And what they do is they give the rats daily intermittent access to a sugar solution and a regular diet. So in other words, the food is there maybe for 12 hours a day, and then there's no food for 12 hours a day. There, I think other regimens were at 6 hours a day, but it's basically you eat now, and then you don't get anything to eat until later. Then they increase the sugar concentration of these syrups. And what they find, I've got to go back a step here. So what they find is those rats who have that restriction phase, the intermittent feeding, they gradually increase the amount of sugar that they take in during that first hour. So basically, they come roaring in, hungry, they go straight for the sugar and eat the other chow as well. And actually, they don't necessarily change their weight. They just go for that sugar treat. And if rats have done this for several weeks and you take away their sugar access, they have withdrawal symptoms. just like an opiate addict has withdrawal symptoms when you treat them with naltrexone. The exact same physiological things in rats. I guess they get all shaky and irritable and do strange things with their heads. Pretty serious. Who would have thought? Just sugar will do that. And then, if they don't give them any sugar for 2 weeks, so that's abstinence, and then they give them access to sugar again in their diet, they eat way more. I think it's like 25% more than the rats who never had that sugar exposure. So we're talking about some lasting changes in their eating habits, and that's because there are lasting changes in the brain. There was another study several years ago that I couldn't find, and one of you may remember it, where someone else had worked with rats and shown that you could only induce them to binging if they had had a period of restricting first. So that may be another piece of it, but I don't know the details of those. All right, so we'll talk a little bit about anorexia nervosa. You're all familiar with that. Relentless pursuit of thinness, preoccupation with dieting and weight loss. And these are the girls who are just paradoxically obsessed with food and eating rituals. It has to be arranged such and such on the plate. There can't be more than 6 pieces of food on the plate. And they're so obsessed about it, as you know, they cook wonderful dinners or bake all these cookies for their families, but they won't touch it. So we've always asked, what's the etiology of anorexia nervosa? And when I first began my training many hundred years ago, it was because of bad mothers. There was a famous book called The Golden Cage that essentially took a very Freudian perspective and said, yeah, your mother screwed you up. Which is too bad, because if your mother screwed you up, it's pretty hard to get fixed. So there definitely is a role of psychosocial influences. Again, if you see your mom is constantly dieting and weighing herself and talking about her food, that's going to make a difference. But on the other hand, anorexia is also a consequence of obsessions and anxiety. And what I want to talk about in a few minutes is sort of how that trait of anxiety and perfectionism can develop into an eating disorder, specifically anorexia. And we do think that it's a primary disturbance of the appetitive circuits in the brain. I'll talk more about that in a minute as well. I'm sure you all know as well that anorexia nervosa is the most lethal psychiatric condition, 10% mortality rate over a lifetime, and 5% mortality per 10 years of disease duration. And 10 years is not an uncommon duration of anorexia nervosa. Suicide is the most common cause of death, and cardiac arrest is the most common medical cause. So I'm going to just fly through the diagnostic criteria. Refusal to maintain weight at or above a minimally normal weight, or failure to gain weight as expected given a child's age. Intense fear of gaining weight or becoming fat, even though the patient is already underweight. Body image disturbances, undue influence of body weight or shape on self-evaluation. I've gained 3 pounds today. I'm bad. And that's a simplification, but except that that's how a lot of people's minds work when they get into this mindset. And I think most concerning from my medical perspective is how people rationalize the fact that essentially they're still alive and kicking, so there's nothing wrong with them. And they're stuck in that image of themselves as being too fat. And, you know, we could show them numbers. Look, your white blood cell count is low. You're malnourished. Look, your C3 complement in your blood, a measure of protein intake, is low. You're malnourished. Your heart rate is low. And people are just kind of immune to that. Every once in a while, it wakes somebody up, and my job as a medical doctor is just to continue giving that feedback to people. Okay, and then the final criteria for anorexia, which again you're familiar with, are amenorrhea for at least 3 cycles in women who have already had periods. And those periods, quote unquote periods, can occur after hormone administration. So lots of times doctors have that reflex, you're not having periods, okay, we'll start you on the pill. Well, what the pill does is chemically induce withdrawal bleeding when the hormone levels in the blood drop. That is not a period, that is withdrawal bleeding. But it's really easy for women to confuse the one with the other. And I had patients where I've explained it 3 times and they still just don't quite get it. But it's a really important concept because so many of these young women we see are on the pill. So sometimes one of my therapeutic steps is we stop the pill and then like, okay, let's see what happens. And then I get stuck because 10% of women with anorexia who are deeply underweight still have menstrual periods. Fortunately, it's only 10%. Okay, and then there's subtypes of anorexia based on whether someone simply restricts or whether they also binge and purge. And again, subthreshold anorexia, lowest body weight less than 90% of ideal, intense fear of weight gain, and no other eating disorder. All right, so what I want to talk about is the work of someone from UC San Diego, Walter Kay. I'm sure you all know that they have now a very well-known eating disorders program that has some very unique features. But he's a lead researcher in anorexia, has been for decades. He was at Pittsburgh before he came to San Diego. And he has developed sort of I guess you will, a proposed mechanism or continuum by which girls develop anorexia nervosa. And what he did in this paper is he differentiated between a trait and a state. So a trait is something that you are born with. An example could be even just right-handedness is a trait, to be very simple about it. So those are genetically determined alterations that contribute to vulnerability. And so if someone is born anxious, for example, that is a trait that contributes to their risk or vulnerability to developing an eating disorder, specifically anorexia. A state refers to alterations caused by malnutrition that may sustain or accelerate development of an eating disorder. So again, you're all familiar with the World War II studies that they did using conscientious objectors who were willing to be starved in order to learn more about the effects of starvation and learn how to refeed people. And these soldiers, once they lost a certain amount of weight, became anorexic. They thought like an anorexic, they talked like an anorexic, they were anxious like an anorexic, they were depressed like an anorexic, and they didn't want to gain weight. So that is the introduction of that malnourished state that makes a big difference when we're working with someone who's underweight because they really can't process information effectively or properly. Okay, so some of the traits that Dr. Kay talks about are genetic vulnerability, which refers again to that childhood temperament and personality traits that predispose, precede, and persist after the development of anorexia. Those are traits that may occur in a family member that doesn't develop an eating disorder, and that makes sense because these are inherited. So sister may be very picky about how she arranges things on her desk. That's really not obsessive compulsive disorder. That's being a little compulsive. But that can develop into, or not can develop into the sibling, the identified patient may be the one who develops full-blown OCD that may center around food, like that plate of cookies. And these trait alterations, as you can imagine, are independent of body weight. So these are things that you're born with. And what the data shows is that this trait vulnerability accounts for, we call it 50 to 80% of the variance in eating disorders. What that means is there's a huge genetic role in somebody's vulnerability to developing an eating disorder. There are plenty of studies of twins that have been raised in different households, and the concordance rate for twins and eating disorders is, I believe, 70%. Anybody know better? It's huge. Okay, so this genetic vulnerability is expressed as, check this out, a diffuse phenotype of continuous behavioral traits. So phenotype is a manifestation of your inborn genetic traits. And the continuous behavioral traits means that you go from obsessively arranging your desk to obsessively arranging the desk and cleaning house to OCD. So it's a spectrum as opposed to a black and white difference. And again, they're heritable. Oh, okay, now I gotta go back again. What was that? I'm sorry, can you help me? Okay, we'll go here. So the predisposing traits, can be present in unaffected family members. We said that. And some of the examples of these traits are negative emotionality, basically tending to dwell on the dark side of things, harm avoidance, and perfectionism, so the opposite of risk-taking. And we talked already about inhibition and the OCD part of things. So the differences then between trait and state are the state-related alterations, which are the changes that are induced by starvation. And the body generally tries to compensate for that by conserving energy and in normal circumstances, increasing intake. And the conserving energy part is the part that's very useful for me clinically, excuse me, I'm sure for you dietitians as well, where you explain conserving energy is why you don't gain weight if you eat normal amounts of food, why your heart rate is low, why your temperature is low. And again, my role as a medical doctor here is just continually to reinforce that those are things that reflect malnutrition. But malnutrition does affect, as I mentioned with the soldiers, mood, cognition, impulse control, and as well as the autonomic nervous system and hormonal systems. There's a sweet spot here. Okay, so this is Dr. K's diagram. Too much for me to even think about developing. So if you go down here on the left, you've got childhood through adolescence through adulthood. Children may have the traits of perfectionism and a drive for thinness. Then they hit puberty. And then they also are undergoing brain development. There are big hormonal surges that affect very critical parts of the brain in terms of eating behaviors. Stress, cultural factors, living in Newport Beach. And that then can lead to dieting behaviors. And so the dieting behaviors then lead to weight loss, which lead to the neurobiological changes that we talked about, and reinforce these characteristics of denial, rigidity, and again lead to anxiety and depression. So girls who have lost a lot of weight get stuck in this cycle. And where we come in is right here. And anorexia is a chronic illness. At least 30% never fully recovered. 50 to 70% reach some level of recovery, and it's really only a minority who can go through the day and not be constantly thinking about their body image and be tempted to diet. The sad thing is, too, that eating disorders can be cured or appear to be cured and then resurface 10 years later. And that's really sad and really hard. So what we do in the eating disorders field is we try to catch them early. So mom thinks maybe she's not eating as much as she used to. She's exercising more. My Newport Beach moms are very attuned to that. And I say, okay, we don't have to call it an eating disorder. We just bring her in, we check things. And sometimes you have to check things for a long time. There is a girl who's 13, I think, who's in one of the Center for Discovery programs now, who had an extremely disturbed family. Mom and dad divorced, bickering, arguing, yelling. Mom suspected to have anorexia, never overtly diagnosed. Dad verbally abusive, if not physically abusive. Daughter seeing therapists for 2 years. Oh, everything is fine. Not giving him access to anything. Mom's concerned because she's gone vegetarian as she hasn't gained weight. Come to see me, yeah. She's relatively very underweight. Her body mass index at the first percentile. She eats dinner in her room because it's so noisy with the family. A year later, or 6 months later, they finally come back in. And they couldn't do follow-up with me because Dad was mad that I had mentioned the divorce when I was talking with the daughter. So they come back in. She's gone through puberty. She's actually now up to like 15th percentile for body mass index. She's still eating dinner in her room. She still thinks Mom has an eating disorder. She goes on. She quits seeing her therapist because she faked his questionnaires to show him that everything in life was perfect or good enough. And lo and behold, one day her mom finds a piece of paper with her pictures and figures, making it very clear that this girl has an eating disorder. And it took her a long time, but finally we got her in treatment. And finally she started talking about the verbal and physical abuse by her dad, the incredible negotiations that her parents were doing. Dad was in the waiting room at the psychologist, now the new psychologist, and he's told the mother that he would allow his daughter to see the psychologist if she gave up her claim to possession of the house. It's going to take a while for this girl to get better. So that's a pretty extreme case, but it does mean that when there's a suspicion, the parent is usually right, and what we have to do is create a non-threatening environment. Sometimes I invent excuses to come back for a checkup. And sometimes just talk really frankly about, this is what an eating disorder is, this is what it looks like, and we don't want you to go there. So I'm going to be checking in with you about these things. Okay, thank you. All right, so this is another Dr. Case Grass, and he's talking here about the temperament and personality symptoms, whether they're mild, moderate, or severe, and how then they can progress and increase based on these variables in adolescence, which is a key time. Which is a key time for the emergence of eating disorders because of all of these stressors, and how then that vicious cycle can develop. And really one of the key points of this slide that's different is that how people who have mild anxiety or perfectionistic traits are more likely to come out of here with a good outcome. The people that start with OCD when they're 10 are going to have a much more difficult time ultimately achieving recovery. All right, so this is an extreme example of what happens to the body in anorexia nervosa. This is a chest x-ray and actually a CAT scan of a woman with a normal body mass index, so an appropriate amount of body fat on the slender side. And this is what happens to the heart in someone who is way underweight. So the heart literally shrinks, and it can't pump blood as well. That's why people get dizzy, faint. That's why they have a low heart rate. And these are some of I don't show them these slides, but it can be helpful for other professionals to understand why this is so serious and why that little girl who's being followed by her sports nutritionist needs to probably see somebody else. We don't have to go back to that slide because that prior slide just shows, again, a long-term complication of anorexia. With young people, it's kind of pointless to say, oh, yeah, your bones are going to be all weak when you're old and you're going to have a hunchback like a 90-year-old. It's just so not relevant to them. But on the other hand, every once in a while, there's a patient who has had a prolonged course of disease, who does develop osteoporosis, and every once in a while, that patient will respond to that information. You just have to keep going back and using these windows, because sometimes one of them will have the effect that you want. And again, I do not use scare techniques. All right, this is probably one of the most famous bulimics of our time, Terry Schiavo. You may remember her. She collapsed on the floor at home, was brain dead, and her husband and her parents had a very, very prolonged and bitter dispute about whether to discontinue life support. Terry Schiavo had bulimia. That's why she collapsed on the floor. And these are pictures of her at various times in her life, and it's really heartbreaking when you go from this picture to that one. But you can also see in this picture the hint of the parotid swelling that we see with bulimia can be subtle. And this situation I do mention to my patients with bulimia, because they have that, oh, not going to happen to me attitude. Okay, criteria for bulimia. Try and move quickly through these. Recurrent episodes of binge eating and recurrent inappropriate compensatory behavior to prevent weight gain. So that inappropriate compensatory behavior can be purging. It can be laxative use. It can be exercising for 2 hours a day, 7 days a week. But there's criteria numbers-wise, both at least twice a week for 3 months. Self-evaluation unduly influenced by body shape and weight, same as anorexia. And again, it does not occur exclusively during episodes of anorexia. Because remember, anorexia has those two subtypes, the purging subtype and the restrictive subtype. And again, there are more subtypes. The purging subtype is with the vomiting. The non-purging are other ways that people compensate for their quote-unquote binging. Classic signs of bulimia, sticking your fingers down your throat to make yourself vomit. That's sort of an early bulimic thing usually, because by the time someone is entrenched in their bulimia, they can self-induce vomiting without anything. The other extreme of that is one of my patients who went to the emergency room with a toothbrush stuck in her throat because she hadn't learned how to do that. So the Russell sign are these scabs on the back of the hand. And the parotid enlargement, again, can be subtle. It's like mumps, where you have a little bit of obscuring of this gland. And this brings me really to one of the reasons I was motivated to give this talk for you guys today. And hopefully her case information is here. No, we'll get back to it. This is another girl who binged. And she binged so much that she could no longer purge. Her stomach was full, and the point where it opened up into the esophagus was a right angle. So nothing had come back up. So she also had to go to the emergency room, and they pumped out 11 quarts of fluid. Extreme cases, but they happen. Signs of bulimia that you see in the mouth, and again, that you guys may notice in the course of sort of routinely seeing somebody with a substance abuse disorder once a day or twice a day. Probably won't be looking in their throats, but those red marks, again, are from purging. Dental enamel is something that actually makes a difference sometimes to our patients here because they don't like losing their dental enamel, and their teeth look really yucky. This is the dentin, the yellow stuff underneath the enamel that's exposed. Fillings sometimes, those old metal amalgam fillings, are just kind of standing out in the middle of nowhere. And it costs thousands and thousands of dollars to restore that. Yes?
Are dentists legally required to report something like this?
The question is, are dentists required to report something? No, they're not, because it is self-harm behavior. But You know, just the same as we're not required to report cutting to an external authority. They don't have that requirement. What's challenging, I think, is that many dentists are not comfortable asking their patients how their teeth got to be like this. Most of my patients say their dentist has never said anything to them. Yeah. And I don't know about your dentist, but my dentist's office is not very private. You know, there's always somebody sitting next to you that can hear what you're saying. And I don't tell him that regularly update out what medications are you taking. I don't tell him anything because I don't want the person next door to hear. So unless the dentist is super clued in and says, can we talk for a couple of minutes, and takes them into his office and says, I'm noticing some changes in your teeth, nothing really is going to happen other than that they're going to get some nice new enamel stuff put on their teeth. Yeah, and then the other thing that you may notice in eating disorders patients, both with anorexia and malnutrition, and with patients who purge, is just this little drawing that you see right there on the corners of the mouth. That's called angular chelosis. Name doesn't matter. If you see someone like that, you should be thinking about it. And finally, we're going back to, that was a picture of the X-Lax home factory. Because getting addicted to laxatives is actually a serious medical problem. The people with bulimia who die usually purge and use laxatives, which totally drains the electrolytes from their body. And withdrawal from laxatives, I don't know, it's probably about as hard as withdrawing from alcohol. I mean, there are very distinct physical symptoms that people get when they're stopping or tapering off laxative use, so it's tricky medically. All right, I think somehow my slide about my patient didn't get in here. So we're going to go one more, talking about bulimia being an addiction. No. Okay, so let me tell you about my patient, who was 30 years old when she came to see me. She got my name off the website because I was close to where she lived. She had one child who was 8 years old, and she came in because she had bulimia. And she wanted treatment for that. This woman had been purging since she was 18. She had been in alcohol rehab 3 times for extended periods of time. She'd even had to go to jail for alcohol-related behaviors, and then got it commuted to an IOP here in Newport Beach. She had PTSD because she had been physically abused by her husband. And she had never told anyone that she purged. Not a single soul. Her husband didn't know. Nobody in any of these treatment centers knew, according to her. And because I know that Sovereign does really try hard and does work with these people that have both conditions, I just think it is so important to do your screening and to do these observations so that she doesn't continue with really what is a double addiction, and ultimately have to get treatment for that. That's a lot of life that is wasted. And I know there's a lot of controversy, I think, in the substance abuse field about how you do incorporate eating disorders treatment into substance abuse. Some programs think that if they just slap in a dietitian, that the problem is fixed. And then they have their regular alcohol, drug abuse staff counseling people with eating disorders. And it doesn't work. Because you know what? You can't quit eating. It's a different set of parameters. Okay, and there is my patient. Okay. Okay, so she's one of the examples of coincidence of these two disorders. Bulimia of patients or of patients who have bulimia, up to 50% also have substance use or dependence problems. And of people in treatment for substance abuse, 35% also have bulimia. Now, does that fit with what you see in your programs? So you're asking the right questions. How often do people come in and not tell you about one disorder when they're seeking treatment for another? All the time, right? So you have to have your sensors up. You have to look who runs from the table right after a meal, and who spends hours in the bathroom. You got to do it. And I will say that I think it's really imperative that you do have staff who are trained, and again, I'm speaking to the choir here, but I've worked with a very exclusive eating disorder program, sort of for this dual diagnosis, and they didn't have anyone monitor the bathrooms after meals. Their patients were just going in and purging, and it's like, oh yeah, she has an eating disorder. Well, are you going to address it or not? All right, so the commonalities between bulimia and addiction. They both have mood-altering effects. There are environmental cues for both of them. There's reinforcement. You do it, you feel better. There's craving. You've got to have that sugar fix. And that's what those rats experience that I mentioned earlier. There's that compulsion to engage in the behavior. There's a disability to prevent yourself from engaging in the behavior. And again, that loss of control. Those are things that both bulimia and substance addiction have in common. So how do you define addiction? According to DSM, a maladaptive pattern of substance use leading to clinically significant impairment or distress, manifested by at least their characteristics at any time in the same 12-month period. Okay, so components of addiction. Tolerance, the need for an increased amount to get the effect, or having the same amount, decreased effect. People with bulimia tend to binge on ever-increasing amounts. That's tolerance. Withdrawal syndrome, or using in order to avoid symptoms. So we know what that is in a heroin addict. In someone who is a bulimic, if they can't purge, they get physical symptoms, sort of like the rats that couldn't get their glucose. There's an actual withdrawal component that has been described in bulimics. The substance is taken in larger amounts or over a longer period than intended. Trying to stop, wanting to decrease your use. A huge amount of time that someone takes for their drug habit or for their eating disorder. Because if you've got bulimia, you often have to go to the grocery store and buy the food. Or you have to hide the food from your mom because she'll complain that it's all disappeared. If you're going to eat a huge amount, it takes a while. And then finally, again, after you've thrown your guts up, you feel bad. Everybody's had stomach flu. You know what that feels like. It's no different if you've done it on purpose. And then because of the time, people give up activities in order to curb their use or due to the use. So for example, can't go to parties because there's no place to throw up afterwards. Everybody else wants to use the bathroom. Just as drug addicts have to cut back on things because they got to go score. I do not have that spot. What if I did this next? Okay. And finally, another characteristic of addiction is that there is continued use despite knowledge of persistent physical or psychological problems due to or exacerbated by the substance. We've walked through that already with bulimia. All right, so what's happening in the brain? I think you all know that the brain is composed of a bunch of nerve cells that interact with each other through neurotransmitters going from one cell to another. And these nerve cells are organized into tracts. So fibers go through different areas of the brain to other areas of the brain. And these are some pretty cool examples, I think, of tracts within the nervous system. I've talked a lot about rat studies, so I want to just show you a rat brain, which is pretty similar to a human brain in some key aspects. This part of the rat brain is called the limbic system. It is the really deep system in our brain that regulates pleasure and emotion. specifically the amygdala and the nucleus accumbens, which you see there. And the VTA is another part of that system. And they have a tract that leads to the prefrontal cortex, where we do our thinking. And here's another diagram that those of you who do a lot of substance abuse work are probably very familiar with. And this shows how two different neurotransmitters, dopamine and serotonin, play roles in the transmission of impulses through the brain. And again, frontal cortex, back here is this impulse control center that I mentioned. Remember, people with addiction and bulimia have difficulty with impulse control. And then there's this deep set limbic system, specifically, again, the nucleus accumbens that is involved in rewards and risk-taking. So we got this circle going here. Okay, and I want to just mention, there, thank you. I want to just mention, because we all know that adolescents are such great risk takers, that the areas of the brain that undergo the most structural changes in adolescence are the prefrontal cortex, cognition, thinking, and the nucleus accumbens and other parts of this pleasure-seeking center of the brain. And we know now that what happens in adolescence is the drive for pleasure from the limbic system, again, including the nucleus accumbens, matures before the prefrontal cortex does. So kids are biologically driven to act out and take risks before their brain can tell them stop. Okay, so how do we tie it together? You saw that dopamine was one of those two neurotransmitters that are listed above there. Dopamine is, for example, in the medial prefrontal cortex. Dopamine levels increase after drugs or after continued conditioned stimulus. And that same increase in dopamine occurs in bulimic patients after food cues. Picture, chocolate, increased activity. And they've done this actually on functional MRIs. So it's real science on humans. And people with anorexia and us normal people don't have that same rise in dopamine in those areas, even when we see the German chocolate cake. Okay, so there's a category of foods that are called highly palatable, which includes sugar, but it also includes foods that have a lot of sugar and a lot of fat. And those foods lead to dopamine release down here in that nucleus accumbens. And the amount of dopamine that is released relates to the degree of sweetness and what the preferences for these foods are during the binges. If you give someone intermittent access to these, humans and rats, that has the effect of increasing the drug dose. And we talked about that with the rats and the increased sucrose. Yes?
Okay, so this has always confused me a little bit. So you have a dopamine release when sugar is ingested, and that we know. So when alcohol and drugs are ingested, you also have a dopamine release, but you also have another chemical pathway that is truly addictive.
It's the same pathway. That is what the irony of it is that addictions take these same pathways. And so
the alcohol, the chemical addiction is this dopamine pathway.
yeah, that's exactly right. It's that mesolimbic pathway. And that's why, for example, when you talk about cross addiction, someone who's sucrose addicted and can have physical withdrawal symptoms. That's not that common in humans, but in rats, you do that. If you give them alcohol without sugar, that subdues the symptoms. Yeah, and that's why now they're starting to use naltrexone to help people that have severe bulimia, because again, it helps with that, decrease that need. Yeah. Okay. Okay, so talking about dependence and tolerance, we now know that, and I think everybody knows, just lay public, there are long-term neurobiological changes that occur with addiction. That's why you're never recovered. Same thing happens with bulimia. They're very similar neurochemical processes, and like you pointed out, same pathways. And that's why there's that cross-sensitization. Sugar and amphetamines, sugar and alcohol. So that does mean you've got to look at eating in the area of substance abuse. You just can't do one without the other. And then we already talked about tolerance and increasing the binge size from that.
I just have one more question.
Yeah.
Do you think that there is more dopamine that's secreted with the drugs and alcohol than with sugar? And there must be some dose.
I'm not sure that that's been measured. It probably has been measured, but I don't know the answer to that. Yeah, I don't know. Okay, so again, we talked about abstinence and how abstinence leads to those neurotransmitter changes. Same thing with sugar-dependent rats. If you take them without sugar for 36 hours, they get withdrawal symptoms. And again, this is what we just talked about, how you can induce withdrawal symptoms with naltrexone. Okay, and what the withdrawal symptoms often are in women with bulimia or people with bulimia are an increased anxiety level, sleep disturbances, and craving. Food craving is for a specific food, and by definition, and this is the definition here, it's not necessarily due to dietary deficiency or restraint, which means that, yes, people may crave foods if their diet is insufficient in a certain substance. How much often does that happen in our society, would you say, you dietitians?
Get it with traveling. I was given the example of traveling in Paris and eating nothing but bread and cheese for a week, and I just wanted meat.
Yeah.
I would say I needed iron, something, so I do get that example.
Yeah, so Deb's example is that if you're in France for a weekend eating nothing but baguette and brie, that at the end of that week, your body is telling you it needs meat. And the example that I give to parents, actually, who are so worried about their children's eating patterns, especially the young ones, there's a classic study whereby if you put 5-year-olds in a room at meal times, over 72 hours, they will choose a balanced diet. Our bodies know this. Okay, binging is associated with lower levels of hunger, paradoxically, right? And we know the craving is much higher in bulimia than in anorexia. We talked about the MRIs. And then negative affect, feeling bad if you don't get your drug. So there's been a lot of talk in the literature about food addiction. And I think that term can be used, but very, very carefully. All those books about curing your sugar habit, I don't think I would buy. Do you have many clients come and ask about that, about sugar? Sure. Yeah. And my classic example of sugar habits is, again, going back 20 years, the studies that were conducted, some of here in Orange County, that says that eating sugar makes kids hyperactive. Well, that's been debunked, totally debunked. A kid with ADD can eat sugar. But there's this association culturally, I think, that's very, very deep-seated. Okay, so the differences between binge eating disorder and bulimia are the type and the amounts of food, whether or not there's purging, big difference in the underlying psychopathology, the comorbid addiction, and again, this spectrum of being a little bit bulimic or really bulimic in terms of the severity of the disorders. So I think the door is open in terms of research on food addiction. I think it's very real in this limited sense. And what I put up here for you who may not be real familiar with the eating disordered world are some links that take you to the best eating disorder sites. And if you want them afterwards, I'll give them to you. So in closing, I would just say, we're in Southern California. We all worry about something. let's take it easy on ourselves. And thank you very much.